Every pill in your cabinet was prescribed for a reason. Your doctor had a plan, you followed it, and for a while it probably worked. But here's the part that rarely gets explained. After 65, your body handles those same pills differently. Your kidneys filter slower. Your liver clears drugs at a different pace. And your heart, the one organ that can't take a day off, has less reserve than it did 10 years ago. A side effect that was manageable at 50 can become a real cardiac burden at 72. That's not an opinion. That is physiology, and the numbers back it up. Every year, nearly 100,000 older Americans end up in the hospital because of adverse drug reactions. Adults over 65 are hospitalized for medication problems at 7 times the rate of younger adults. 7 times. I'm Dr. David Okafor. I spent more than 20 years in internal medicine, most of that treating patients over 60 with cardiovascular conditions. And what I see again and again isn't reckless prescribing. It's incomplete conversations. So today, 7 common medications that can quietly strain an aging heart. And I'm not just going to scare you with a list. Every one of these comes with a safer option and a specific test you can ask for. Not a warning list, a complete conversation. Tell me in the comments, how many prescription bottles are on your counter right now? Whether it's 2, 5, or 12, drop that number. I read every single one, and it shapes what I cover next now. We're counting down from 7 to 1, and stay for number 1. Because it's not a single pill. It's something far more common and far more overlooked. Most families never see it coming, number 7. Dronedarone, this one catches people off guard because it's an antiarrhythmic, a drug designed to control irregular heart rhythm. So the assumption is it must be protecting the heart, right? Not always. In patients who already have heart failure, Dronedarone can make the pump weaker. I think of a heart that's already climbing a steep hill. This drug can make the hill steeper, and we're not guessing here. A clinical trial called Andromeda tested Dronedarone in patients with severe heart failure. The death rate in the Dronedarone group was more than double, well, technically 8% versus 4%, so just over double. But the trial was stopped early. That doesn't happen unless the signal is serious. So what's the conversation to have? If you or someone in your family takes Dronedarone, ask your doctor one direct question. Was this prescribed knowing about any heart failure history? Because if there's weakness in that pump, the treatment options shift. Amiodarone with careful monitoring, or rate control strategy instead of rhythm control. Different tools for a different situation. And here's the test to ask for. An echocardiogram, it measures your ejection fraction, the percentage of blood your heart pushes out with each beat. That one number tells you whether Dronedarone is a reasonable fit or a risky one. All right. Number 6, and this one connects 2 conditions that most people think of separately. Number 6, Thiazolidinediones, pioglitazone and rosiglitazone. These are diabetes medications used to improve insulin sensitivity. And for blood sugar, they can work. But here's the part that often falls through the cracks. The doctor managing your blood sugar may not be the same one watching your heart. And these drugs carry a cardiovascular cost that doesn't always make it into the diabetes conversation. The mechanism is fluid, literally. These medications cause your body to hold on to extra fluid. Not dramatic swelling at first, more like slowly filling a water balloon that's already stretched thin. The heart doesn't feel the first extra ounce, but it feels the 10th. So here's the question nobody asks at the diabetes visit. What is this drug doing to the heart while it's fixing the blood sugar? The evidence isn't subtle. A major analysis in the New England Journal of Medicine found that rosiglitazone increased the risk of heart attack by 43%. That number led to an FDA black box warning and years of restrictions. Pioglitazone carries a separate warning for heart failure hospitalization. So what do you ask for instead? There are diabetes medications that actually protect the heart. SGLT2 inhibitors Drugs like empagliflozin or dapagliflozin have shown real cardiovascular benefit in clinical trials. Metformin remains a solid foundation if kidney function allows. These aren't obscure alternatives. They're well-studied options your doctor can evaluate. And a test to watch, track your weight daily. A sudden gain, more than 2 pounds overnight, isn't diet, it's fluid. Ask for a BNP blood test if you notice breathlessness or swelling, and make sure your kidney function panel is current. That panel helps guide which alternatives are safe for you. Number 5. And this one's going to surprise people who think of it as just a sleep pill or a mood pill. Number 5. Tricyclic antidepressants, amitriptyline, doxepin, nortriptyline. These are prescribed for mood, nerve pain, migraines, and sleep. And yes, sometimes they help. But they also touch the heart's electrical system in a way that deserves more attention than it usually gets. The concern is something called QT prolongation. You don't need to memorize the term. What I mean is, the heart's electrical reset takes longer than it should. Think of a traffic light that takes too long to cycle back to green. Cars start moving at the wrong time. That's what happens inside the heart when the QT interval stretches. The rhythm can stumble. Research shows that starting amitriptyline increases the QT interval by roughly 8 to 9 milliseconds on average. That sounds tiny, but in an older adult who already has a slower heart rate, lower potassium, or who's taking another drug that also affects the QT, those milliseconds add up, and the risk is dose dependent. So the higher the dose, the wider the gap. Here's something I want you to hear clearly. Some of you have been on one of these medications for 15, 20, even 30 years, and nothing has happened. I believe you. But the body you had when that prescription started isn't the body you have now. Your kidneys cleared the drug differently. Your electrolytes may have shifted. Your heart has aged. Years of safety isn't a guarantee for the next year. That's not fear. That's just how biology works. So what do you ask about? For depression, sertraline is generally considered safer for the heart. For nerve pain, gabapentin or pregabalin. For sleep, low-dose trazodone or melatonin. Discuss the fit with your doctor and a test. An ECG with the QTC interval measured, especially if you're on more than one drug that could stretch it. Now, the next 3 are ones almost everyone recognizes. And number 1 isn't what you expect. Number 4, proton pump inhibitors, omeprazole, pantoprazole, esomeprazole. If you've ever dealt with acid reflux, you probably know these well. And look, when reflux is bad, these drugs can make a real difference. The problem isn't the drug itself. The problem is time. Most PPIs are studied for 4 to 8 weeks of use, but many people stay on them for 4 to 8 years. The reflux improved, the prescription stayed, and somewhere along the way it stopped feeling like a medication. It became furniture. That's where the silent cost begins. Your stomach acid isn't just an inconvenience. It plays a role in absorbing magnesium. And magnesium is like the steadying hand on a metronome. Remove it slowly enough and the rhythm starts to wander before anyone notices. In 2011, the FDA issued a formal safety warning. Long-term PPI use can cause dangerously low magnesium levels. They reviewed dozens of cases involving arrhythmias, seizures, and abnormal heart rhythms. And in about 1 out of 4 cases, magnesium supplements alone weren't enough. The drug had to be stopped entirely. So what's the conversation? Ask your doctor whether a step-down plan makes sense. Full dose to half dose. Half dose to an H2 blocker like famotidine. Famotidine to lifestyle adjustments. Smaller meals, head elevated at night, no eating 3 hours before bed. That's a real off-ramp, not a cliff. Oh, and this one comes up a lot. Many of you ask whether food can help with magnesium. It can. Dark leafy greens, spinach, Swiss chard, pumpkin seeds, almonds, black beans, avocado. These aren't replacements for a prescription, but they're part of a conversation about whether your body's getting what it needs while the medication runs in the background. And the test? Serum magnesium. Here's the thing most people don't know. Standard blood panels often don't include magnesium. You have to ask for it specifically. If you've been on a PPI for more than a year, that test should be on the list. Repeat it every 6 to 12 months. Quick pause. If this is helping you see your medicine cabinet a little differently, take 1 second and hit subscribe. It helps us reach more families who need to hear it before their next refill. All right. Number three, certain calcium channel blockers, specifically diltiazem and verapamil. I want to be precise here. Not every calcium channel blocker carries this concern. Amlodipine, for example, works differently and is generally safe for the heart muscle. The ones I'm flagging are the non-dihydropyridines, diltiazem and verapamil. Different chemistry, different risk. These drugs reduce the force of heart contraction. For someone with a strong pump, that's manageable. But for someone whose heart is already working at 40 or 45% capacity, imagine asking someone who's already carrying 2 heavy grocery bags to also walk uphill. The legs can only give so much. Same with the heart, and this isn't a gray area in the guidelines. The American Heart Association and the American College of Cardiology classify non-dihydropyridine calcium channel blockers as potentially harmful in patients with an ejection fraction below 50%. That's a class 3 recommendation, meaning the evidence says don't use them in that population. So here's the practical question. Do you know your ejection fraction? Most people don't, and that's the gap. Prescription can lower blood pressure nicely on the chart, and everyone looks at that number and says good. But if the pump behind that number is getting weaker, one improving metric can hide a worsening body. What do you ask for? An echocardiogram. It gives you the ejection fraction, the percentage of blood your heart pushes out per beat. If it's above 50, these drugs may be appropriate. If it's below that, the conversation changes. Amlodipine, ACE inhibitors, ARBs, these are alternatives with proven benefit in weaker hearts. I'm not saying diltiazem or verapamil are bad drugs. I'm saying they belong in the right heart. And the only way to know is to measure number 2. And this one, you almost certainly have it at home, number 2. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, diclofenac, these are everywhere. Prescription cabinets, bathroom drawers, travel bags, bedside tables. People reach for them for knees, backs, shoulders, headaches, a little inflammation, a lot of pain, and a bottle that never seems to be far away. Here's the science in plain terms. These drugs tell your kidneys to hold on to salt. More salt pulls in more fluid. More fluid means more volume for the heart to push. And if blood pressure rises at the same time, the workload doubles. It's like leaving a garden hose running into a pool that's already full. The pump doesn't get a break. And get this. A large study across 4 European countries found that current NSAID use raised the risk of heart failure hospitalization by about 20%. And in adults over 80, the risk nearly doubled. So what do you do about pain? Because the pain is real. Nobody's dismissing that. But there are options that don't load the heart. Topical diclofenac gel, applied directly to the joint, delivers about 80% less drug into your bloodstream than the pill version. For general pain, acetaminophen with careful dosing. For chronic joint pain, a referral to physical therapy can do more long-term good than any bottle. These aren't exotic alternatives. They're conversations worth having. And the test? Basic metabolic panel. That covers kidney function, creatinine, eGFR, a 2-week blood pressure log at home. And if you notice any swelling or breathlessness, ask for a BNP level. Now let me tell you about someone I'll call Grace. Grace was 74, lived alone, still drove herself to church every Sunday. Her knees had been bone on bone for years, the kind of pain that makes you negotiate with every staircase. She kept ibuprofen in 3 places: the kitchen, the car, and her purse. She didn't think of it as a medication. She thought of it as getting through the day. Over 6 months, her ankles began to swell. Her blood pressure climbed from controlled to concerning. She gained 8 pounds without changing how she ate. Her daughter noticed she was breathing harder after walking from the parking lot. When we reviewed everything together, the full list, the frequency, the timeline, the pattern was clear. The pain relief had quietly become a cardiac burden. We shifted her to topical gel for the knees, added physical therapy twice a week, and adjusted her blood pressure plan. Within 2 months, the swelling went down. Her breathing came back. Her weight dropped. She looked at me and said, "Nobody ever told me there was another way. I thought ibuprofen was just what you did when you got old." And now, number one. And I told you this one would be different. The most dangerous medication in an older adult's home isn't any single pill. It's the combination. I told you at the top, the biggest risk isn't one pill. It's the pile, the full pile sitting together on the counter, prescribed by different doctors, renewed at different times, and never reviewed as one picture. Think of it like 5 people each pulling one thread from a sweater. No single pull tears the fabric, but 5 at once and it gives. One drug holds fluid, another slows conduction, another drains magnesium, another reduces contraction force, another stresses the kidneys. Each one may be reasonable on its own. Together, they're a system under pressure that nobody counted. I always have to repeat this number to myself because it still doesn't feel real. More than 40% of Americans over 65 take 5 or more prescription medications. Nearly 1 in 5 takes 10 or more. And polypharmacy among older adults has nearly doubled in the last 20 years. That's not because people are sicker. It's because the system adds faster than it reviews. Many of you have asked a question that deserves to be heard. Can we really prescribe the same drug at the same dose to a 45-year-old and a 78-year-old? Here's the thing the system often does, because it's faster. But your body isn't a generalized chart. Your kidneys, your liver, your heart reserve, none of it matches the clinical trial population anymore. And some of you have been on the same medication since the 1980s. That doesn't make it wrong. But the body you had when it was first prescribed isn't the body you have now. A drug that fit perfectly at 55 may fit differently at 78. And I hear this too. Some of you have tried to reduce a medication and the rebound scared you. Your chest tightened. Your blood pressure spiked. That fear makes sense. And it's also why I keep saying this is about a conversation, not a cold turkey decision. A step-down plan with monitoring, with a timeline. Not guessing, a plan. Here's the bottom line. The biggest risk isn't a bad pill. It's a pile of reasonable pills that no one has reviewed as a whole. Fix that one problem, and you reduce a tremendous amount of avoidable harm. So now that you have the full picture, here's exactly what to do with it. I need to say this plainly. Don't stop any medication on your own. Suddenly stopping blood pressure drugs, rhythm drugs, or mood drugs can create new problems fast. That's not what today is about. Today is about a review, a real one, a documented medication review that includes the heart, the kidneys, electrolytes, your age, and the complete list, prescriptions, over-the-counter pills, supplements, everything. You're not asking for less medicine. You're asking for the right medicine. For the heart you have today, not the heart you had a decade ago, and not the heart from a clinical trial population. Your heart, your age, your reality. And if your doctor seems rushed or pushes back, that's okay. You can bring this list back next visit. There's no deadline on getting this right. Here's the checklist I want you to carry into your next appointment. 6 tests. Write them down or take a screenshot right now. 1, serum magnesium level, especially if you've been on a PPI for more than a year. Standard blood panels usually skip this. You have to ask 2-BNP or NT-proBNP. This measures strain on the heart. If you have any swelling, breathlessness, or unexplained fatigue, this test tells you whether the heart is struggling. 3, echocardiogram with ejection fraction. If you take a calcium channel blocker, Dronedarone, or have any heart failure history, know your number. Below 50% changes the entire conversation. 4 basic metabolic panel. That's kidney function, creatinine, EGFR. If you use NSAIDs regularly or take a TZD for diabetes, your kidneys are part of the story, 5 ECG with QTC interval. If you're on a tricyclic antidepressant or any combination of drugs that might affect the heart's electrical timing, get the QTC measured. 6, a complete medication interaction review. And here's a tip most people don't know. Your pharmacist can often catch interactions that fragmented doctors miss. Bring every bottle to one pharmacist and ask them to run the full list. Before your next visit, try this. Put every bottle on the table, prescriptions, pain pills, reflux tablets, sleep aids, supplements. Write 3 things beside each one. Why am I taking this? How long have I been taking it? What changed after I started? That little exercise exposes more risk than most people expect. And tonight, just tonight, pick one medication from this list. Write its name on a piece of paper. Beside it, write one question you'll ask at your next appointment. That's the start of the complete conversation. If this gave you one question you didn't have before, subscribe, because the next video covers which common symptom combinations actually point to a medication problem, not just aging. That conversation may save you months of confusion. Protect the heart you still have. Not with fear, not with denial, with one good question at a time.